Good morning, everybody. Welcome again to another day of the CU sessions. Without any further ado, I hand over to Dr. David, who's going to talk about critical appraisal of a population-based cohort.
Good morning, everyone. Today we'll be doing a critical appraisal of a population-based cohort study. So I'll start off the session by looking at two case scenarios. Let's compare these two patients. The first patient is a 58-year-old farmer from a village near Katpadi. He presents to a secondary level government hospital with worsening breathing difficulty. This patient presents with exertional dyspnea, worsening on lying down, with lower limb swelling, reduced urine output and fatigability while working in the fields. He's got known risk factors of hypertension, diabetes. He smokes 10 BDs per day. He's not compliant to his medications due to various reasons, and he's never had any evaluation done with regards to an echocardiograph or an ECG done previously. On examination, he was tachycardic. His BP was on the higher side. He had features of heart failure in terms of elevated JVP, pitting pedal edema. He had a displaced apex, and he had a systolic murmur at the apex, and he had basal crepitations in the infrascapular areas. Just looking at his investigations, his renal functions were slightly elevated. We can see that his HbA1c was 9.2, which indicates that his diabetic control was not good. He had features of pulmonary edema and cardiomegaly on the X-ray. His ejection fraction was low, and he had a functional MR. So at this point of visit in the government hospital, he was asked why he waited so long and to seek healthcare, why he was not compliant to his medications. And the answer was he was either not aware that it could cause multiple complications, or he had financial constraints. Subsequently, he developed recurrent heart failure admissions over the next year, and he died within 18 months of diagnosis. Now let's look at another patient. This is a 58-year-old accountant from Washington. He visits its primary care physician for mild exertional dyspnea, which he noticed while climbing stairs. He noticed these symptoms over the past 1 week, and he's had no similar complaints in the past. He's also a diabetic, he's a hypertensive, he's a dyslipidemic, he's an ex-smoker, but he's reformed. And he's on all medications for the comorbidities. He's on anti-diabetic agents, including an SGLT2, he's on statins, he's on ACE inhibitors. On examination, these were his vital signs. He had no overt features of heart failure. He had a mildly displaced apex. There were no crepitations. So echo showed an ejection fraction of 40%, which is reduced. His NT-proBNP was done, which was elevated. A coronary CT angiogram identified few atherosclerotic changes, for which he was immediately referred to cardiology. He underwent an angiogram. He's undergoing cardiac rehabilitation, and he's on regular follow-up. 5 years later, he remains alive with no heart failure hospitalizations. So we can see that we've seen two different patients, one patient from rural Tamil Nadu, one patient from the US, and they've both had comorbidities of hypertension, diabetes, both have smoked in the past, and both have presented with features of heart failure. So let's look at why their outcomes were so different. So what we'll be looking at, we'll try to understand the difference between these two patients in terms of what factors contributed to the difference in the progression of disease in these patients, and what risk factors or what could be done to improve outcomes in these patients. For this, we'll be looking at this particular study, heart failure among 1,73,000 community dwelling participants. They've looked at 25 low, middle and high income countries in the PURE study. This was published in the Journal of American Cardiology in April 2026. So to start off, I'll just like to talk about what a cohort is. A cohort is a group of subjects or people who share a defining characteristic. And these are longitudinal studies. We look at exposure, and we look at how they predispose the person to develop a particular outcome. These are longitudinal prospective cohorts. Just looking at this diagram, we can see that there is a study sample or the population at presentation. We screen the population, we look for healthy people, we remove people who already have the outcomes that we are looking at, and then we follow them up prospectively. And out of these, certain people can have exposures which we are interested in studying. For example, hypertension or diabetes could be an exposure, and the outcome could be heart failure. So we look at people who had the exposure, like hypertension, diabetes, other risk factors, and we compare them with people who don't have the exposure. And then we follow them up in time to see who all develop the outcomes and whether these risk factors predispose them to develop this particular outcome. So a simple diagram which shows what a prospective cohort is. Now, what are population-based cohorts? We look at a defined population in the community and we follow them up longitudinally to assess exposure and outcome relationships. So we are recruiting directly from the community, and so the aim when we recruit from the community is that it would represent the general population. For example, the Framingham Heart Study, which was done in 1940, is a famous prospective cohort, which is a population-based cohort. So a few things, what do we calculate in terms of when we do a cohort study is the incidence rate we will be able to assess in a prospective cohort. What is the incidence of the outcome? In other words, what is the incidence of heart failure that the patient develops? What is the relative risk or what is the hazard ratio to develop of a particular risk factor contributing to a particular outcome? However, prospective cohort studies take a long time, hence they are costly. When you're following up thousands of patients over a long time, there is natural to be loss to follow up. So these are all few inherent flaws with the design. So I'll be appraising this article using the CAS checklist. We'll first look at, are the results valid? Should we even look at the results? And then we look at what the results are and whether these results will help locally. Let's come to the first part. Did the study address a clearly focused issue? So in this study, we can see that they've selected adults aged 35 to 70 years, and they've selected these patients from communities in low, middle, and high income regions of the world. So they've looked at 25 countries over 5 continents, and their study was from 2019 to 2019. So they've looked at adults in communities in low, middle, and high income regions of the world in 25 countries. Coming to exposure, so when we looked at the cohort flow chart initially, we saw that there are people who are exposed to a particular risk factor and people who are not exposed. So here they looked at 13 risk factors, of which 10 were grouped into cardiometabolic risk factors, which is diabetes, hypertension, non-HDL cholesterol, abdominal obesity based on their weight circumference, waist-hip ratio. They've also looked at behavioral risk factors like tobacco, alcohol, diet, and physical activity. They've looked at low education, which is a marker of socioeconomic strength, household air pollution, physical strength, depression, and self-reported ischemic heart disease. These are the exposures that they wanted to assess. And the control naturally would be lack of exposure or if someone does not have hypertension, they are the control. Someone does not have diabetes, they are the control. Coming to outcomes, they looked at heart failure events, and they looked at first fatal or non-fatal heart failure events. Secondary outcomes were mortality after a first heart failure event. So 30-day, 1 year, and 5-year mortality after a first heart failure event was looked at. The follow-up was every 3 years. They've included participants who completed at least one cycle of follow-up. And in this, the median follow-up was 14.9 years. So my critique of this was, did they address a clearly focused issue? Yes, they are looking at incidence of fatal and non-fatal heart failure. They've chosen the population, and it's a multinational prospective cohort. They've looked at a large population in 25 countries. They've assessed a lot of risk factors which can contribute to the incidence of heart failure. So I would say they've addressed a clearly focused issue. Coming to whether the cohort was recruited in an acceptable way. So let's look at what countries they looked at. So they've chosen 25 countries and they've grouped them into high income, upper middle income, low middle income, and lower income countries. We can see that among the high income countries are Canada, Saudi Arabia, Sweden, UAE. Among the low income countries are Bangladesh, India, Pakistan, Tanzania, Zimbabwe. And the lower middle income countries are China, West Bank, Iran, Philippines, Kyrgyzstan. So they've chosen a lot of countries and stratified it by income level. They've also done a stratification by geographic region. South Asia, Southeast Asia, and in India, India comes in the South Asian stratification. So they've selected a wide range of countries. They've stratified based on the income level and based on the geographic region. Now let's look at how they selected countries, communities, how they selected individuals as well. So when we look at countries, we've seen the stratification. They've classified into high income, middle income, low income countries, and the bulk of the recruitment was from low and middle income countries. Now how did they select the communities within these countries? They've looked at urban and rural communities. So they've selected rural rural communities that are isolated or at a distance of more than 50 kilometers from urban centers. But they also wanted these communities to be able to have been followed up. So I would not say it's a random national sample. They have chosen certain urban and rural communities based on how easy it is to follow them up. And they mentioned consider feasibility for long-term follow-up for urban communities, such as choose residential colonies related to specific work sites and developing communities. So it's not a random national sample. They've chosen specific communities within these countries, which will help them ensure less loss to follow-up. Now, how do they choose individuals? They've said they've done a broad representative sampling of adults of 35 to 70 years. And they wanted to consider feasibility for long-term follow-up. So this is what we've already looked at. So it's not a random national sampling, but they've chosen specific communities and individuals which would help them ensure less loss to follow-up. Now the advantages of this particular design I would consider were it is a multinational cohort. It's included urban and rural communities. It's stratified by geography and income. However, the cons would be that the generalizability may be affected because it's not a random national sample, and there might be some selection bias based on the method of recruitment that they've done. Coming to the next question, was the exposure accurately measured to minimize bias? So let's look at what the exposure was. We've already seen this in our opening slide. They've looked at 10 cardiometabolic risk factors, which is hypertension, diabetes, abdominal obesity. They've looked at behavioral risk factors. They've looked at education, air pollution, depression, ischemic heart disease. So they looked at all these risk factors. Coming to this is present in the supplementary table. So we would like risk factors to be objective. But a lot of risk factors such as tobacco use, alcohol, diet, physical activity, all these were measured on the basis of self-reported exposure. So in these outcomes, I would say it is quite subjective. A person may not be forthcoming with how much tobacco he is smoking or how much alcohol he is consuming. Diet was measured based on a questionnaire and they've dichotomized it. A diet score of more than 5 is good. A diet score of less than or equal to 4 is not good. Physical activity was measured based on the International Physical Activity Questionnaire. So I would say all the questionnaires are standardized, but there is a component of subjectivity among all these self-reported outcomes. Risk factors. Coming to the objective risk factors, they've looked at hypertension, where it was defined as a systolic BP of more than or equal to 140. Diabetes, but they've also included a self-reported history of hypertension or treatment with antihypertensive medications. They looked at diabetes, which is a fasting glucose of more than 126 milligram per deciliter, HDL cholesterol, and abdominal obesity. I would say a lot of these are objectively measured. So this is quite good. Coming to socioeconomic and psychosocial risk factors, they've looked at education, which was again self-reported. They've looked at household air pollution, which is again self-reported use of solid fuels. So it's a mix of self-reported outcomes and objective outcomes, which is why I've given that it's not a yes to whether the exposure was accurately measured. So there is some amount of bias in this. Now coming to the next question, was the outcome accurately measured to minimize bias? I've given probably yes for this question. Let's look at what they classified as outcomes. So the outcome in the study was congestive heart failure event, and they've labeled it as fatal if death occurred within 30 days of the first heart failure presentation. So how did they define? So they've classified heart failure or the outcomes into 3. One is definite, one is probable, and one is possible. So for definite heart failure diagnosis, the diagnosis should be made with should have signs and symptoms of heart failure like crepitations, increased JVP, pedal edema, and symptoms like nocturnal paroxysmal dyspnea, dyspnea at rest, ankle edema, along with few objective measures like radiological signs of pulmonary congestion, or if the patient was being treated with diuretics. So this is definite heart failure. Now, probable heart failure is the signs and symptoms of heart failure in a person with comorbidities like hypertension, history of previous MI, or heart disease. While possible heart failure is signs and symptoms of heart failure we do not know about the risk factors. So this is how they've characterized the outcomes into definite heart failure, probable heart failure, and possible heart failure. Now, how do they adjudicate these outcomes? Who decides what is heart failure? They mentioned that they have a central adjudication in each country by trained physicians. This is the exact line they have mentioned in the study. They have ensured to ensure a standard approach to class and accuracy for classification of events. The first 100 cardiovascular events for China and India were adjudicated both locally and by the adjudication chair centrally. So they've used a central adjudication process to ensure a standardized method by which heart failure is detected. However, let's look at certain disadvantages. The event documentation. So this is mainly in low income countries and low middle income countries. There was a lack of medical records, death certificates in these areas. So a lot of the event documentation was based on household interviews and what they thought was the cause of death, verbal autopsies. So this could lead to a bias in detection and classification. An important thing to note was that echocardiographic data was available not in a lot of people. It was in fact present only in 12% of the population. So that is again reduces our objectivity in detection. Middle income countries and low income countries lacked a central death event or central death or event registration. Now another important thing is they've looked at incident heart failure. Is the person assessing the incident heart failure blinded, or does he know what are the risk factors? That is again something that is not clearly mentioned in the paper. But again, when we look at how you classify heart failure, it itself has inherent risk factors incorporated into it. In the sense they have someone who is having probable heart failure should have known hypertension or previous MI or ischemic heart disease. So it becomes a bit difficult for the outcome assessor to not know what the risk factors are. So that is another disadvantage that I found. So overall, I would say it is they have tried to do tried to reduce bias by central adjudication by standardized forms, but there were few disadvantages in these in low and middle income countries, which I have enumerated. Now coming to whether the authors have identified all important confounding factors. So I've given this as probable yes. We'll explain how they have adjusted. So we already saw that they've selected certain risk factors, cardiometabolic, pollution-based, and they've mutually adjusted for each of these 13 risk factors which we looked at. They've adjusted for age, sex, and based on their geographic location as well. Now most major confounders, I thought that they could have looked at certain other risk factors like chronic kidney disease, atrial fibrillation, valvular heart disease, medication use, socioeconomic gradients other than education. This could have played a role which they have not adjusted for. They've mentioned that they've used a multi-variable cause-specific Cox shared frailty model to estimate the hazard ratios and 95% confidence interval, accounting for clustering within communities, and they've included each community as a random intercept effect or a frailty term. So I'll just attempt to explain what I've understood by this particular sentence. So multivariable is there are a lot of variables, 13 risk factors, age, sex, all those they have tried to adjust for. Now a Cox shared frailty model is a mathematical model to look at events over time. They've looked at a cause specific Cox model. There are other models like joint frailty models which look at competing events. For example, if death occurred prior to heart failure, how do they adjust for that? So those are other mathematical models. Here they've used a cause specific Cox model. Now I'll just explain what included each community as a random intercept is and what is the frailty that they mentioned in this paper. So a standard Cox model was assumed that every participant is independent of every other participant. So that means someone from rural Tamil Nadu is equal to someone from the US. Here there are patients from India, patients from Canada, but we know that it is not technically correct. Coming to the next point, certain participants from a particular area will have inherent risk factors which can predispose them to developing the outcome. For example, someone from Javadi may have a similar diet, healthcare access is not good there. Someone they may or may not have pollution exposure, socioeconomic status. All these factors may play a role in them leading to the outcome. Outcome in our case is heart failure. So how do we assume that every participant is independent? We cannot. So the first point is we cannot assume all participants are independent of each other participant. We cannot assume that participants in one particular community may be independent of each other because they may have some inherent risk factors which are correlated. So the outcomes in these particular participants in one community may be correlated. Now what have they included as frailty in this? It's a hidden risk factor which we cannot directly measure. So if we assume two communities, let's say A and B, they have identical risk factors. When we looked at the case scenario, we looked at one patient from Washington, a patient from rural Tamil Nadu. Both had hypertension, smoking and diabetes, but one developed a worse outcome while the other developed a relatively good outcome. So if two communities have identical measured risk factors and community A still develops more heart failure, what is the cause for that? There could be multiple causes like we've already discussed: poor healthcare access, environmental factors, nutrition and genetics. All this they've incorporated into a term called frailty. So they've used this term to identify a hidden risk factor which each community as a cluster could have. Now let's say community A has a frailty term mu A, community B shares a frailty term of mu B. If this particular frailty is 1.5, then community A has a 50% higher underlying heart failure risk. This is excluding the risk factors that we have mutually adjusted for. If the other community has a 0.8 risk, community B has a 20% lower heart failure inherent risk. So here they mentioned that each community is included as a random intercept effect or a frailty term. So they've used this mathematical model to assume, to incorporate this particular frailty term into each while calculating the hazard ratios. Now why is it important? So let's assume that the hazard ratio was 3 for hypertension in rural Tamil Nadu while it was 1 for hypertension in Canada. Is the 3 only because of hypertension, or is it because there are other inherent risk factors? So without using this frailty term, it can overinflate the hazard ratios of a particular community. So that's why they have used this frailty term to reduce the bias in calculating the hazard ratios. So is that okay?
You bring down that 3 because
yeah. So you might widen the confidence interval and bring down the hazard ratio by using this shared frailty term. So that's what they have mentioned by shared frailty. And again, the Cox, they've used a cause-specific Cox model. There are other Cox models like joint frailty models which help in dealing with competing events. Here they've used a cause-specific Cox model. I won't be going into much details with that, but I hope everyone's understood what a shared frailty is and what they've incorporated into this particular model. That's a mathematical model. Yeah. Now, hazard ratio is the rate of an event occurring in a particular patient over time, assuming that they've survived till a particular point. So how do we know that the hazard ratios are remaining stable through the 15 years of follow-up that this patient had? So they've tested this using other mathematical models like a proportional hazards model. They've tested using Schoenfeld residuals and log plots. I won't go into much details, but that is basically looking at the changes in hazard ratio over time. And this is something that we'll be discussing. What is a population attributable risk factor? So essentially that is the proportion of events that occur in a population that could proportion of events that can be avoided if a given risk factor is eliminated. So let's assume that this community A has developed heart failure. How much and hypertension's population attributable fraction is 25%. If we eliminate hypertension, that means the incidence of heart failure in that community will come down by 25. We'll come to how a simple population attributable fraction, how it's calculated and they've used a complex model here, but we'll try and explain that as we move on. So here the adjusted model that they've looked at has included totally 9,829 patients. We saw that the total number was 1,77,000. So the model which had all the variables for all the risk factors was around 64% of the total cohort. Now let's come to, is the follow-up of subjects complete and was it long enough? For this, this is a figure that they've given. We can see that they've included participants who completed at least one round of follow-up, which is every 3 years. So 1,77,933 participants in 25 countries were eligible for follow-up, and 1,74,728 completed at least one follow-up, which is quite good because the follow-up, only 3,205 did not complete at least one follow-up. That's only 1.8% of the total cohort. So I would say that the loss to follow-up is quite less. Now coming to the median follow-up period was 14.9 years. That is an adequate period to detect heart failure. So I would say that the loss to follow-up is less and the time of follow-up is also adequate in the study. But an interesting thing that we would have liked to know was, is there a differential loss to follow-up based on the economic or their income stratification and geographic region? Are people in low income countries and medium income countries less likely to follow up? That differential loss to follow up has not been given in the article, which is something that we would have liked to know. Now let's come to our overall impression of the article. I think that it's a prospective multinational large scale cohort. They've included 25 countries, 5 continents, included urban and rural communities. They've stratified by geography and income, which is a major plus for the paper. We've seen that the follow-up is quite long. The median follow-up is 14.9 years. They've used a standardized case report forms. They have a central adjudication process. They've looked at clinically relevant outcomes, which is incident heart failure, fatal and non-fatal. They've adjusted for a wide range of confounders, and they have very low loss to follow-up. All these are strengths of the study. A few disadvantages. We've already seen that the sampling was not entirely random. It was not a random national sample. It was stratified by certain areas which could ensure less lag to follow up, less loss to follow up. They've excluded 35 to 70 years. They could have included adults more than 70. So the elderly people are excluded from the study. There are self-reported exposures which we've just looked at in terms of their diet, in terms of their physical activity. All these are self-reported exposures. There is some missing data in terms of complete data is available only in 64%. And there is a possibility that heart failure could be underdiagnosed in low-income countries because of the medical records, the death certification, the imaging availability is all not as good as in a high-income country. And the echocardiographic data to objectively say this person has heart failure with reduced EF or classify the heart failure is not available, and it's available only in 12% of the cohort. So my overall impression that it is, we should look at the results because it is a large scale cohort, and we would like to know based on our critique so far, I think it is good to look at the results. So results we'll be classifying into what the results are, how precise are the results, and should we believe the results. Let's look at what the results are. First, we'll look at what are the incident rates of heart failure. This is stratified by income setting. So we can see that the overall incidence rate is 0.39. So that is per 1,000 patient years. Or in other words, if you follow up 10,000 people over 1 year, around 4 people will have heart failure. Now they've stratified it as high income, upper middle income, low middle income, and low income. We can see that the incident rate of heart failure is maximum in the upper middle income. But the low income countries have a very low incident rate of heart failure. Is that something that you think is plausible? We have, let's say in India, do we see that much less heart failure than in another country like US? So we'll keep that in mind. So here low income countries are, India comes in low income countries. So this is something that we'll keep in mind when we look at when we go on to the next result. Now they've stratified the incident rates of heart failure by geographical region. So let's look at South Asia. India comes in South Asia. We have the least amount of heart failure. Again, is that something that we usually see? No. whereas sub-Saharan Africa had the highest. We can expect that. I would expect South Asia to be just next to it. So as per this, we are even less than North America, which is a high income country, which is not very plausible. They have attempted to explain this going forward. We'll look at it. Now, we already saw that heart failure classification was divided into three. One is definite, one is possible, and one is probable, where definite included chest x-rays and patient to be on diuretics. So we can see that in the high income country, 87% of the detected or incident heart failure cases were definite, which meant that they were on diuretics or they had chest x-rays to corroborate the physical symptoms. Whereas if you look at low income countries, 55% of the incident heart failure was only possible, which means that patient reported symptoms of breathing difficulty, whereas we did not require x-ray, either we did not have x-ray or so the most possible explanation could be that a lot of heart failures were missed. Just because of the lack of access to healthcare facilities, people did not have the other corroborating medical records to show that it is heart failure. So this is, so we saw in the first two diagrams that the low income country incidence was less, and we can see that out of the detected cases, 55% were only possible heart failures.
But did they count this in the total?
Yeah, they counted everything in the total incident heart failure, possible, probable, and definite. Now let's look at non-fatal and fatal heart failures. So these are the total heart failures in the low income countries, out of which 59% was fatal, which means that all patients who presented with heart failure died within 30 days, near 60% in low income countries, whereas that percentage was 11% in high income countries. So that's something else that we need to keep in mind. Now, as per region, when we look at South Asia and Sub-Saharan Africa, more than 60% of the people who presented with incident heart failure had fatal outcomes, which means they've died within 30 days. Now, I'll just look at age and sex adjusted mortality. When we look at high income countries versus low income countries, the first bar graph is 30-day mortality, 1-year mortality, and 5-year mortality. We can see the difference between a high income country and a low income country. How much of the difference which shows the adjusted mortality after an incident heart failure based on the country income group. This is based on the geographic region. So we can see that there is quite a high divide between a high income country and Sub-Saharan Africa and South Asia, where our mortality is quite high. So what can explain the apparent low incident rates and high mortality in low income countries? So anyone would like to give your opinion as to why heart failure incidence is so low, but among the heart failure cases detected, the deaths are quite high. Yeah, so a lot of people may not present to hospital. Let's say rural communities are 50 kilometers away from a hospital or a healthcare center. So they may, if they are able to live with the symptom, they live with the symptom. Unless they cannot absolutely and they are taken to the hospital with overt symptoms of heart failure, admitted, they may not do well after that. So I would explain this observed pattern of low heart failure incidence and high early case fatality rate. It does not reflect a genuine low burden of heart failure, but it's reflective of the consequences of our healthcare system and heart failure detection. So the authors have also given a good diagram to explain how it changes in low income and high income countries. Let's say in low income countries, the heart failure symptoms are often unrecognized. If people are able to manage with the symptom, they carry on. There is a delayed or no access to diagnostic care, imaging, or seeing a cardiologist or a physician. Patients usually present with advanced heart failure at first presentation, by which time their ejection fractions are low and they would require to be on multiple medications, following which they may not even take the medications if they are not able to afford the medications, which leads to a higher proportion of fatal first heart failure events. So that could explain the low observed incidence and the high early mortality. Whereas if you look at a high income country, the patients will already be well managed for their comorbidities like hypertension, diabetes, there is a ready access to imaging, biomarkers. They'll be started on guideline directed medical therapy, and hence their detection rate is high, which leads to a higher observed incidence, and they have a low mortality. So this could explain the differences which we just saw in both the populations. Now let's look at this Kaplan-Meier survival plot. So I'll ask a few of the registrars to explain what this plot means. The light green one is reflective of low middle income countries and low income countries, and the blue one is high income countries and upper middle income countries. So this is looking at a survival from, so at point 0, everyone is alive. As we move, this is time in years. So as we move to 3, 6, 9 years, we look at how many people survived. Nishit, can you explain what, let's assume at 50% survival. So this is the point at which 50% of our population is alive. Okay, can you explain the differences between the two graphs?
Higher income and upper middle income countries, more people are alive, 50% people are alive at 6 years, but in lower income and low income, it's about 1.5 years.
Yeah, so we can see that the time at which 50% of the population remains alive is 1.5 years for low income countries, whereas it's 5 years for upper and middle income countries. Now let's look at the other way. Let's look at 3 years. What's the difference? Joel, can you explain? So when we look at 3 years, is it the same? How much percentage of the population is alive at 3 years in higher income countries? Around 60%. How much percent of the population is alive in low income countries? Around 40%. So that's just a visual explanation of how to interpret a Kaplan-Meier survival plot. Now they've also mentioned what are the etiologies. We've looked at certain risk factors and the hazard ratios. We'll come to that in the next table. So this is a country income level stratification of the risk factors. So we can see that the dark blue is hypertension, the light brown is ischemic heart disease. So across all the regions, ischemic heart disease and hypertension contributed the most for incident heart failure. Now, when we divide by region as well, we can see that the two most important risk factors among all these regions were hypertension and ischemic heart disease. Now we look at the hazard ratios that they mentioned. So this is education, which they've looked at as a marker of socioeconomic status. We can see that a primary school or less had a significant hazard ratio to develop heart failure. That was an overall hazard ratio. We look at current smoking, also had a significant hazard ratio. These comorbidities, which we've already looked at, hypertension, ischemic heart disease, diabetes, all had significant hazard ratios. And these hazard ratios were mutually adjusted for each other risk factor. Now let's come to this particular fraction. We'll learn a bit about what is a population attributable fraction. Essentially, it looks at what percentage of the disease cases in a population could be prevented, or in this case, what percentage of heart failure could be prevented if you eliminate a particular risk factor. So it depends on two variables. One is prevalence of exposure in the community and the strength of association. So the prevalence, let's say if 25% of the population smokes, the prevalence is, we're looking at an example where smoking causes lung cancer. So let's say if 25% of the population smokes, the prevalence is 0.25. The strength of association, the relative risk for smoking to cause lung cancer is 2.5, which means smokers are 2.5 times more likely to develop disease than non-smokers. This is a very simple formula. This is not what they've used here. Can we just calculate what is the population attributable fraction in this example? When the prevalence is 0.25 and the relative risk is 2.5. How much did we get? How much? 0.27. So when we convert into a percentage, it's 27%. So if you stop smoking, the risk of lung cancer reduces by 27%. This is wrongly given. So population attributable fraction essentially looks at the prevalence and the strength of association and calculates a fraction which is an inherent population risk. It's not an individual risk. So let's look at what they've given in the population attributable fraction here. So here it's not a simple equation. They've looked at multiple risk factors. It's not as simple as smoking and lung cancer. They've looked at hypertension, diabetes, diet. So they've done multiple permutations and they've used this mathematical model called Ide and Gefeller to calculate the population attributable fraction here. And let's look at the first column, which looks at hypertension. The population attributable fraction in hypertension was 24.6%, which means that if you eliminate hypertension, you can reduce the risk of incident heart failure by 24.6%. Even primary education had a significant population attributable fraction. Ischemic heart disease and diabetes also had significant PAFs. This is something that they found in this particular study. Now we've looked at all the results. Now let's look at what this particular criteria is, Bradford-Hill criteria. So looking at the strength of association, we've looked at the hazard ratios. We've seen that the strength of association is good in terms of hypertension, ischemic heart disease, diabetes, all leads to an increase in heart failure events. What is consistency? They've looked at multiple areas, right? They've looked at stratified it by income level, by geographic region. We can see that across all the regions, hypertension and ischemic heart disease led to an increase in heart failure events. Coming to, we look at temporality, which looks at is hypertension or the risk factor like diabetes preceding the incidence of heart failure. That is with regards to temporality. With regards to dose-response relationship, it's not something that we've done here. Here they've taken dichotomous outcomes in terms of do you have hypertension, do you not have hypertension. They have not mentioned hypertension more than 160 systolic, more than 140 systolic. It's not a dose-response relationship that they've done here, but that is what's the meaning of dose-response relationship. Specificity means will a specific exposure cause a specific outcome. Again, it's all interlinked. Hypertension is not the only thing, or it does not only lead to heart failure, it can lead to other cardiovascular diseases. So it's not specific. Temporality is present, dose-response relationship is not present. Plausibility, it's entirely plausible. Hypertension can cause left ventricular hypertrophy, it can eventually lead to a failing heart. Coherence, again, there are multiple studies which have looked at similar events, which have shown coherence into what the study has already proposed. Experiment is, can you eliminate hypertension in a person and have two groups where you control or in other words, you can strongly control hypertension and the other person to have not uncontrolled hypertension, and does it lead to a change in outcomes? It's not something that we can readily do because it's not ethical to control hypertension in one and not control hypertension in the other. Analogy is can similar risk factors cause the outcome? So diabetes all lead to atherosclerotic heart disease. So that's what we mean by analogy. So when we look at Bradford-Hill criteria, we cannot say that all these risk factors are causal for heart failure, but they have an association with heart failure, is what this criteria essentially looks at, association versus causation. Now let's look at, will these results help locally? We look at these three questions. Can the results be applied to our population? Does it fit with other available evidence? And what are the implications of the study? So I've just put the baseline characteristics of the population that they've looked at. We can see that we already know that they selected adults between 35 to 70 years. The median age of these population was between 50 to 60 years. We can see that current smokers were much more in the incident heart failure group. Our aim is to look at whether this population mimics our population. So let's see, hypertension, 67% of the patients with heart failure had hypertension, which is what we see in our population. 14.6% of the population only had ischemic heart disease, which may not be very reflective of our population. Only 25% of the people with diabetes had heart failure, which is again we see a much more increased incidence of diabetes in our population. Now we'll see, is the cohort study an appropriate method for this? Yes, because it's had an extended follow-up. Its median follow-up duration was 14.9 years. We are looking at exposures again like education, smoking, which are difficult to do in a randomized control trial. India is one of the participating countries in this particular trial, but they've excluded elderly population, and in Vellore at least we see a larger proportion of diabetes and hypertension. So this is what they've given in the supplementary. We can look at India had around 29,000 participants were from India. So I would say it is applicable to our population, even though there are certain differences in the patients we see in our setup. These are the institutes they have looked at within India. They have looked at St. John's, PGI. So across India, they've looked at these 5 institutes. Now there is a lot of other available evidence. I won't be going into that, but which looks at income-wise, geographic-wise stratification, prevalence of heart failure, and the risk factors. So there is a lot of evidence which corroborates what this study shows in terms of its risk factors. Now, what are the implications? I would say that this is a large multinational cohort, and they've enumerated the population attributable fraction of risk factors, which we've already looked at, showing that hypertension and diabetes, hypertension and ischemic heart disease contribute a lot to the incident heart failures. They've attempted to describe the differences in heart failure incidence and mortality across different socio-economic levels. We've looked at low-income countries, high-income countries, per geographic region, South Asia, Sub-Saharan Africa, and North America. So we've already looked at a possible explanation for why it's different among these two countries. So the lack of access to healthcare, the lack of early diagnosis, lack of detection. So ultimately, it's absolutely essential to strengthen our existing healthcare system in order to ensure early detection of heart failure and manage them well, which is what the takeaway from this particular cohort study would be. So coming to our 2 patients which we started off with, we had a patient from rural Tamil Nadu who presented with heart failure with a lot of these risk factors, hypertension, diabetes. He's a smoker. He presented with heart failure. Did he present early on when he developed heart failure? He presented quite late, right, when he could not carry on his regular activities. He presented late, and he was started on goal-directed therapy, but he defaulted. He expired within 18 months. The second patient is a person from the US, where he developed heart failure again, but he developed early. He presented early to the hospital. He was put on guideline-directed medical therapy. He was compliant to it, and he remains well without symptoms. So we attempted to look at what factors contributed to the difference in the progression and what could be done to improve outcomes. So ultimately, apart from the existing healthcare system, we need to improve management of comorbidities like hypertension, ischemic heart disease, diabetes, are things that we can control in our setup as a physician. Whereas on the larger role, the healthcare system and accessibility needs to improve.